Hello, everyone. Welcome to our webinar, Your Questions Answered MIGS for Glaucoma Patients. My name is Michelle de Elizalde, and I am the Director of Patient and Research Programs at Glaucoma Research Foundation. I'm now delighted to welcome Dr. Christine Funke, a board-certified ophthalmologist and fellowship-trained glaucoma specialist at Barney Delaney Perkins Eye Center in Phoenix, Arizona. Dr. Funke earned her medical degree from Rush Medical College, completed her internship at Resurrection Hospital in Chicago, and went on to residency training in ophthalmology at Case Western Reserve University in Cleveland, before completing a glaucoma fellowship at the University of Illinois Eye and Ear Infirmary. Her commitment to long-term patient care and innovative treatment makes her an outstanding leader in the glaucoma field. Please join me in welcoming Dr. Christine Funke.
Thank you, guys. It's so lovely to be here. Thanks for inviting me to this talk. And this is unique for me because I get to actually talk to patients out there, probably my favorite thing to do. And probably my favorite subject, which is talking about minimally invasive glaucoma surgery. I am a glaucoma surgeon who was kind of raised in the area before MIGS was even available, and it's really become a huge passion project for me. So talking about this, trying to give you guys information about what MIGS are, what MIGS are available, and how that may benefit your life, and how I've seen it benefit my patients is going to really be our goal today. So with that, we'll get started. Full disclosures, I do work for several different companies as a consultant. A lot of this is actually helping developing and researching a lot of the different products that we're going to be discussing. So in a lot of ways, I think having these disclosures is good. It lets you know that I really am up on what we're talking about today. So before we get started, I think it's nice to understand the anatomy. And when you have a surgeon coming to discuss something with you, or an optometrist, anyone who's understanding the world of glaucoma, it's really good to first understand what part of the eye we're even talking about. So this is a little quick anatomy review, nothing that you need to memorize, but basically we're saying, where do these minimally invasive glaucoma surgeries go? Where are we talking about in the eye? And so this area is actually internally in the eye, and you are looking at the junction between the cornea, which is the front surface of the eye, and then the iris, which you can see, which is the brown part, which is flat there at the bottom part of the picture. And in between where the cornea and the iris meet is the area that is the drainage structure in the eye, which we also call the angle. So you can hear a bunch of different words. And more specifically, you'll a lot of times hear the trabecular meshwork. This is an area that we are actually having the most, I would say, resistance to flow in most patients with glaucoma. So the trabecular meshwork is a little meshwork, kind of like a sieve, that overlies the opening into the actual drainage structure in the eye. And that a lot of times can get clogged up with debris. It can get disorganized. It can get scarred. And that's one of the reasons that patients' eye pressures go up. And this is also a target area for a lot of our minimally invasive glaucoma work. And right behind that trabecular meshwork is the Schlemm's canal. So that's the area that actually all the fluid flows into before it flows downstream into your veins and the rest of the body. So just to kind of understand some of the anatomy and what are the areas we're talking about, this is the general space for most minimally invasive glaucoma work. So a great question always is, how does glaucoma happen? And here's a video looking at the area we were just discussing, which is that angle, and looking at the flow pattern of natural aqueous humor, which is the fluid in the eye. And first, you're going to make that fluid behind the iris, which is the brown part. It will flow through the pupil and then into the trabecular meshwork, which is that little cage that you saw. From that area of the trabecular meshwork, it goes through the meshwork and then into the canal of Schlemm. That Schlemm's canal is going to then be directly connected to the rest of the drainage structure out of the eye through collector channels. And all of these pieces of the eye eventually can have some form of obstruction or scar tissue, which causes an elevation in pressure leading to glaucoma, which ultimately is optic nerve damage, which is in the back of the eye. So just so you kind of have an idea of what's causing all of this issue with increase in pressure and thus downstream issue around the optic nerve and optic nerve head destruction. So, what is minimally invasive glaucoma surgery, right? That's always a good question. And so it's MIGS is just that. That is what it's called. It's just a little acronym for it. And what we're talking about is looking at devices that help improve outflow. So all the flow we've been talking about, and thus bringing the eye pressure down, which is one of the few forms of things that we can work on to control your glaucoma. We can do this either ab externo, which means from the outside of the eye working towards the inside, or from ab interno, which is more the typical approach where we're going from the inside of the eye to take care of this meshwork. Also, we're trying to not manipulate any other areas of the eye. So we're trying to leave everything as natural as we can. A lot of times I talk about these as something that's rejuvenating. So we're trying to really work with your own anatomy, with your own architecture, and trying to make things healthier and functioning better than they are currently. And we're trying to leave other areas that we use for more traditional glaucoma surgery, like the conjunctiva, which lies over the white part of the eye, the skin. And that's the area what we use for more like tube shunt surgeries and trabeculectomies, which again was the more typical procedures and were more invasive than what we're talking about now. Safety profile is one of the biggest things that we discuss as to why MIGS has become such a large standard of care now for glaucoma surgery. And it's because this is a much safer, low risk procedure compared to anything else that we've ever had and what I learned as a resident and fellow. Some of the data we're still collecting, we're getting much better data around all of these minimally invasive surgeries, but really they've been around now for about 10 to 15 years. And so we're still learning a lot compared to traditional surgery, which we've had around for, several decades. Surgical time. So instead of thinking about traditional surgery, which is usually a 20 to 40-minute process, we're talking about shorter surgical times, which increases the amount of safety. We're also going through minimal small openings into the cornea, so that also decreases our risk and increases our surgical efficiency. And also rate of recovery is much quicker as well. So all of these are big positives when we start to talk about doing glaucoma surgery. So it used to be glaucoma surgery was something that we would really wait until the end of disease process. And now we're really actually flipping that paradigm and saying that doing these minimally invasive work, not only is it something that is safe, so it should be used earlier in disease, but actually is more effective when we do this at the beginning of disease as opposed to waiting for later in the disease process. And a lot of that really just has to do with that angle we talked about, which is the angle is more modifiable and we can rejuvenate the angle a lot easier if we work on it earlier in disease than later. And it's just because we don't have as much scar tissue. This is an overwhelming slide. And again, don't memorize it, but it's just showing you how large this category of minimally invasive glaucoma surgery has become. We have a ton of different options here, and there's actually more than what is on this list. So know that when you're talking to your surgeons, you can discuss what their favorites are or talk to them about what MIGS they like to use. But it's really a very large category and it's really broad, which is great. Now we're going to step back just a moment. And where does MIGS fit in with how we're treating glaucoma now? And so one thing you may have heard, or maybe not, is a buzzword that we're talking about a lot in terms of ophthalmology generally, is called interventional glaucoma. Interventional glaucoma is when we are looking at glaucoma in a very different way. We are not sitting and waiting for disease to progress anymore. We are taking the reins and really trying to manage your glaucoma as surgeons for you instead of giving you topical medications and trying to handle it yourself. So this is a much more proactive approach to treatment than we've ever had in the past. And a lot of that has to do with just the minimally invasive glaucoma surgeries we have available and realizing how safe and efficient they are. And so because of that, and seeing how well they work for long-term control of disease, as well as slowing down the progression of the visual field, which is what we want. We want to save your vision. And so with that, if we can be more proactive and more early in intervention, we know that we usually tend to do better with long-term better outcomes from your glaucoma. This is also, we're looking at more early intervention with procedure. So if you think about interventional glaucoma, you can think of it as me as your surgeon. I am the one taking control of your disease. And I am going to be the one who's trying to modify things and get things under control instead of giving you the reins. And this is really just a huge shift in mindset of how we're looking at glaucoma. And we're really starting to see this trend taking off within the world of ophthalmology. So it's something that I think as individuals with glaucoma or those who you know who have glaucoma, it's a good discussion to have with those who are providing care so that you can understand where they're sitting in how they like to treat glaucoma and if they're more interventionally forward, and if they're not, why. So when we talk about this interventional approach, there's traditional ways that glaucoma was taken care of, which we've talked about, which is eye drops, more eye drops, and then waiting finally till we do lasers and filtration surgery. That was the old paradigm or the legacy paradigm of how we treated this disease. And a lot of that had to do with what was the safest. And at that point in time, topical medication was the safest approach for treatment. Now things have really changed, and we've gotten so much data to support that when we talk about procedure, a lot of our minimally invasive or non-invasive, meaning SLT, which is a laser procedure, drug delivery systems, and then MIGS have become so safe and effective that we're starting to use those early in disease state and then waiting or using medications just intermittently to get things under better control in between these procedures. And the reason for that is multifold. One, most patients just tend to not remember their drops as consistently as we want. Two, even those who are taking their eye drops and taking it perfectly, the drops just don't manage 24-hour control of pressure the way that minimally invasive glaucoma work does or any sort of IG practice does. And so for that, we just know that we have better control of your eye pressure 24 hours a day if we physically go and take care of the eye. And third is that patients really have a hard time with eye drops, not only remembering to take them, but there's a lot of side effects. And so when we start to look at adverse effects of those taking eye drops versus those who are doing, say, a laser procedure, we find that the eye drops actually have a lot more side effects than a lot of the procedures that we're talking about doing. So that's where we've really shifted our mindset into something that's much more interventional, because it's really ultimately better for everyone out there who needs treatment. So let's go into some of the MIGS that are available here in the United States. So luckily, in the US, we have more options than most other places in the world. We're very lucky there. And here's just a little snapshot at some of the things we're going to talk about. And we'll go into depth a little bit more about each of these different options. So first, I say this is the OG of minimally invasive glaucoma surgery, which is the iStent. The iStent came around right when I was finishing my fellowship. So over a decade ago now that we've had this in the market, and we've had several iterations of this stent since. But what this stent is a small micro stent. I usually tell people it's about the size of a tip of Lincoln's nose on the penny, so pretty darn teeny. And it's going to go into the trabecular meshwork and then stent into the canal of Schlemm. So you can kind of think about it as purely what we say, which is a bypass. We're trying to make a small micro opening that stays open because you have a stent in place, where we can bring fluid directly from the anterior chamber across the trabecular meshwork, which is the area where we have a lot of, remember, scar tissue, debris, and we're trying to bring fluid more directly into that canal and then out to those collector channels and then out to the veins of the rest of the body. And so with that, that stent is just trying to basically skip the problem that we see in most patients, which is the trabecular meshwork. We initially had one stent, and now we're using 2 to 3 stents. And we know that with more stenting, we tend to have better control of the pressure. So this is one of my favorite ways of getting better pressure control. And this can be done in conjunction with cataract surgery, but this also doesn't need to be with cataract surgery. It can be done without cataract surgery. So here's how that 3-stent system looks. And you can see that there is a hole at the top of this stent, which is actually, if you're looking at the pictures or images, it's actually that flat round disc. Underneath that disc, there's a hole. And then there's also multiple holes around the head of the stent, which you see closer to the top. That top part actually goes into the canal. And then that flat part with the hole is going to be in towards the inside of the eye. I'll show you a video to make it a little bit easier to understand. So here's the video of the stent. Don't worry, it's only just some graphics that were created, but we're going to place that micro stent with a little teeny tiny incision. and then with a small injector. We can place that injector right into the trabecular meshwork, as you can see, penetrating through there and then placing the stent nice and gently. That stent will just stay there for the rest of your life. It is safe. It is compatible, and then you'll see how we're going to have extra flow go through those little micropores or stents, and then into the canal, and then out to the veins of the rest of the body. So a really nice, gentle way of basically augmenting your drainage structure, getting your drain to work better on its own, which is the goal. Hydrus. So Hydrus is also a micro bypass stent. It's a little different than the eye stent that you just saw in that it's a little larger in size. So it covers about 1/4 of the drainage structure, and it has a bypass component, and then it also has a component that actually dilates the Schlemm's canal, because we know that not only is the trabecular meshwork a problem, but actually for a lot of people who have glaucoma, that canal right behind it can also get scarred down and small. And so this stent will help open it up and keep it open so you have better and more natural flow. With that, again, only one single stent that we need for this bypass. But again, a little bit more in the fact that you're getting a multimodal response, meaning that we're going to bypass as well as open up the canal at the same time. So here's another video just showing placement, a little different than the first stent that you saw, but generally the same idea of going through that trabecular meshwork, getting access into the Schlemm's canal, and then you're going to place the stent. The stent threads, I say it looks kind of like an eyelash, and it threads in and through the canal with just the tip of the stent staying out into the anterior chamber, where you can have extra flow of the fluid going into the stent. So here's that stent engagement, and then you can see these little micro windows. Those micro windows are what's keeping the actual internal drainage structure open. And then ultimately the end portion of the stent is what's going to keep extra flow going in through the canal. So now we'll talk about something else. So we've talked about the two major stents that are available for minimally invasive glaucoma surgery, but there's other options outside of just bypassing the trabecular meshwork. Then we can also talk about something called ab interno canaloplasty. Canaloplasty is a giant word basically meaning roto-rooter of your drainage structure. So now we're not talking about the trabecular meshwork as much anymore, but we're actually talking about internally that drainage structure that we talked about, how we can get scarring and stricture of that drainage structure or the canal of Schlemm. Now we want to go in with a different device that's a small catheter. And those small catheters are going to actually incise into the drain, which runs 360 degrees around in a nice hoop or circle inside the eye. And we can open up and dilate that network of drain. This also does help to some degree with cleaning out the trabecular meshwork. So when you're working on pushing this fluid in through and around the drainage structure, it actually goes both upstream and downstream, cleaning out some of the trabecular meshwork, as well as going downstream, cleaning out some of those collector channels. So it's doing a lot of different things when you're using it, but the main goal of canaloplasty is just cleaning out the drain. With that, there's a bunch of different devices out there, all trying to do basically the same kind of work, where we're cleaning out the drain, just a different way of doing it. So, whoever your surgeon may be that wants to do canaloplasty for you, just know that it doesn't really matter to the device. It's whatever's comfortable in their hands, but we got a lot of different options out there that work slightly differently. Here's one option that I use often, which is called an eye track. The eye track is a teeny tiny catheter that we place into the drain, and you can see it moving on this image. And what it's doing is you see a little light. The light is just indicating that we can tell we're in the drain the whole time. So you can see it right underneath the white part of the sclera, and we see that little light blinking as we're cleaning out the drain. And what we're doing is just pushing this very thick fluid into the drainage structure to open it, dilate it, and to get things functioning better. So again, this is just a gentle way of rejuvenating your drain, or kind of pushing your drain to wake up and say, we need a little help here, we need a little support. This drain has been used for 50, 60, 70 years and has had a little wear and tear, and we want to rejuvenate it. So that's the way that we open it up with canaloplasty. Now, you might hear two different terms, canaloplasty versus a goniotomy. Both similar, a lot of the same different devices that we use to do them, but they're a little different in what we're trying to accomplish. So canaloplasty, like we talked about, is just cleaning out the drain, a rotor-rooter, but we're leaving everything that you have naturally there intact. This is different than a goniotomy. A goniotomy is when we're actually going to unroof the trabecular meshwork. So you remember with those stents, we were bypassing the trabecular meshwork. Some people have such sick trabecular meshwork, so much scar tissue that it's actually better for them if we unroof it completely and get direct access into the canal. And that's called a goniotomy. There's a couple different other options to do goniotomy that are different than some of the canaloplasty devices. So just know there's even more devices out there that are purely used to open or unroof that sick trabecular meshwork. This is something that I will use in people who have had narrow angles in the past. If you've heard that as part of your discussion with your surgeons or other physicians. And sometimes if I'm seeing a lot of scar tissue or somebody who has steroid-induced glaucoma. So there's a lot of great reasons to use a goniotomy. Now another class of devices. So the third class of devices are technically not minimally invasive glaucoma surgeries, but they are drug-eluting devices. But they still go in a similar area, which is inside the angle. We have two different options here, and unfortunately, I'm so sorry I didn't have a video for you, but I'll describe them. The first one is an iDose, and the second is a Durysta. They are both medication-eluting devices that are eluting a prostaglandin analog. For you, that means latanoprost, Travatan, Lumigan. That's all a similar drug class that would be these medications are being eluted into the eye. What's nice about these devices is you're getting something that's going physically inside the eye, so you don't have to remember your drops. Also, what's nice is you're not going to have any surface issues. So if you get dry eye because of your medications, if you get irritation, if you feel like you look red, all of these different things are going to be negated because the medication is physically inside the eye. They're also made as a preservative free. So you don't have to worry about if you have any issues with preservatives. That's also avoided here. The best part for me as a glaucoma surgeon is it is 24-hour medication that is going into the eye. And we know that if I do a topical eye drop, it initially brings the eye pressure down over about an hour or so, and then it slowly starts to go back up again. So even if you are absolutely perfect with your medication, the amount of medication physically working inside your eye is variable throughout a 24-hour period of time. But we can bypass that issue by placing these different kinds of devices. Durysta was the first one that came out onto market, and it is actually an injectable. So teeny tiny little pellet that gets injected into the front part of the eye. This can be done in clinic. So it's something I do. I just have patients lay their head back. We numb up the eye so they don't feel anything. And then you can place this medication directly in the eye. This medication lasts for about 4 to 6 months of actual medication in the eye, but we are seeing IOP, which is your pressure, respond for even as long as a year and a half based on studies. So that's a really nice option. By the FDA, we can only inject this one time. So that's its limitation. The iDose is a little different, that it's actually a physical device that has the medication inside of it. And there is a little teeny tiny sieve, and it slowly elutes the medication 24 hours a day for several years. Average of 2.5 to 3.5 years, up to 5 years that we're seeing efficacy for this, but you have to go into the operating room to have it done at this point. It is a simple procedure to perform. It doesn't take long, and it is a longer lasting, but it is something where, again, quick trip for a quick procedure in the operating room for that one. But I do like both of them because, again, it's negating the problem of compliance for patients, meaning not remembering their medicines, which is very common for most people taking even one medication, but especially several. And it also gets rid of the problem of a lot of the surface issues that come with medication. So these are a little bit newer in our world of glaucoma treatment, but it's becoming quickly, I think, some of the favorites. And then finally, this is a Zen gel stent. Zen gel stents I put in the category of minimally invasive bleb surgery, or a MIB. So a little different than what we're talking about, but still this device is going to be half in the angle and then half underneath the conjunctiva. So it's kind of a mixture, I think, of our minimally invasive glaucoma work mixed with our traditional glaucoma surgery. So for me, as a surgeon, this is something that I usually am using more after I've tried the other things, such as laser, minimally invasive glaucoma surgery, as well as the drug-eluting stents. And then comes into the world the Zen gel stent. Zen gel stent is something where we are basically saying that the drainage structure that we've been talking about is no longer functioning the way we want it to, and so we want to bypass it. But we want to bypass it in a more gentle and controlled fashion. And so with that, we have a little stent, which you can actually see in the picture there. It's pretty hard to see, which is a good thing, right? We don't want it big device that you can see, but you can see this little yellow teeny tiny stent up there, and that little stent is bringing fluid from the inside of the eye out underneath the surface of the eye and then out to the veins of the rest of the body. So a little bit of a different path. This can be done in many different methods. Per your surgeon and how they are feeling in terms of their comfort level of how they like to do a Zen gel stent. But this is a really nice way of bypassing that angle when the angle is just not giving us the amount of drainage we need, and we need better control in a different way. So with that, I think you guys are up to date, at least as much as I'm up to date on the things that are available. I can't tell you enough how lovely it is to be here, and thank you for inviting me. And also just know that I can't be a bigger advocate also for learning this technology as patients, so that you can feel empowered to talk to your providers about options, and just know there's a lot of options out there, and there's a lot of great options that can control you, low risk, safe procedures where we can get away from the traditional topical medications, which we know are fraught with issues.
Wow, Christine, thank you so much. That was amazing. All the information that you provided, it was maybe overwhelming for some. It was a lot.
I'm
It was
sorry, there's a
no, no,
lot out
no.
there.
It was super useful. And with that, we have lots of questions, obviously.
Sure. Yeah, yeah.
Just as a general question, what would you describe as some of the major risks, both short and long term, for MIGS procedures?
So the beauty of MIGS is that very honestly, the risks are very minimal. When I talk about risks of MIGS, I talk about it akin to cataract surgery. So most of you out there potentially have had cataract surgery. You know what the risks around cataract surgery were, which were very small, 0.001% risk of complication of having any kind of infection. That's the biggest one we are concerned about usually with surgery, and that's very, very small. There's also a risk with MIGS of bleeding. That is usually very transient, meaning within 24 to 48 hours, it's gone. It's not something that's going to affect you long term. Most people will have a little inflammation. The amount of inflammation we get is so small. When I do standalones, I actually am not using steroid postoperatively anymore. So that's basically telling you this is so gentle that your body's not having a massive inflammatory response to it. So, really, I think that we've gotten to a place where we're very safe with these procedures. We've been doing them long enough that we've gotten very good at it. That I would put the risks minimal to, again, the same as cataract surgery, if not even maybe slightly lower, because we're not in the eye as long.
That's amazing. That's really
It's
good.
really nice. It's really nice. It's some of my favorite things to do for people.
That's fantastic. And kind of along that lines, at the beginning you mentioned that an ideal situation is probably to go into an area where there's not that much scar tissue.
Mhm.
But what about type of glaucoma? What would you consider and I guess an ideal candidate for this kind of
Sure.
procedure? Does the type of glaucoma, whether it's normal tension or pseudo exfoliative glaucoma, would that make a difference?
So in some ways, yes, probably with what minimally invasive I'm going to choose. So say, for example, pseudoexfoliative. Pseudoexfoliative, we know there's a lot of debris clogging up that trabecular meshwork. So for them, actually cleaning it out, blowing out the trabecular meshwork, or even unroofing it, which is the canaloplasty goniotomy option, a lot of times works really well in that subset of patients. Anybody with open angle glaucoma is always a good candidate for minimally invasives because, again, we're wide open. We can do whatever we want. Um, The only people who I would say are probably not minimally invasive glaucoma candidates is somebody who's had a true angle closure, a true angle closure that's long term. So if you had an acute angle closure attack, if I can get into your eye, take out your cataract, and open up the drainage structure, you're actually great for MIGS. But if it was there and has been there, that scar tissue for say 10 years, we don't tend to have as much success. Does it mean you can't try? No, but I usually tell people that our rate of success is more 50-50 as opposed to a usual 80% chance of better success there.
Thank you.
Sure.
Um, okay, trying to pick all these questions. So how long does a mixed procedure last, and
Mhm.
can it be repeated if necessary?
Yep.
And it's kind of a multi-question question.
Okay. You might have to remind me some of them.
No problem. If you want, answer that part, and then I'll get
Okay.
to the second
So
part.
one is you got to understand research is really hard to conduct. So, from a perspective of how long do things last, we've got some answers, but not as many answers as I think all of you would probably want. And probably I would want to as a surgeon, because following people for study after 2 years is very unusual. So, know that most of our data, unless it's retrospective data, meaning data that was collected after procedure was done and the weren't washed out, it wasn't like a the traditional way that we do study, usually 2 to 3 years. We have one study, which is around the Hydra stent, which actually followed patients for 5 years, which was huge and landmark. And for those patients, we'll talk about that one, which for those who had the hydrus with cataract surgery, so it was a combined,
Hmm.
more than 60%, it was actually 66%, still had pressure reduction and medication reduction at 5 years' time. So for the majority of patients, they were doing really well. And this is a cohort of patients who are, some of them were 1 med, 2 med, and 3 med patients. So that mixes up some of that data. But what I usually tell patients is, one, unfortunately, glaucoma is not curative. I wish it was. It is a progressive disease, and it's going to progress no matter what we do. So we know that if I do a laser one day, I know that's not going to be the last thing. It's the same with doing cataract surgery with minimally invasives. It's probably not going to be the last thing, especially if you're going to hang out with us for the next 10 to 20, 30 years. So we know that this is progressive, and our treatment has to be progressive with the disease. And everybody's different with how fast they progress and when they need the next treatment. I hope that for most of my minimally invasives, I'm going to get at least 3 years up to 5 years out of it, and some people even longer. As opposed to repeatability. Yes, it depends on what procedure we're doing as to the repeatability. We're getting very good at doing eyeball acrobatics, meaning that usually we're tending to do surgery in the nasal angle. So the angle which we talked about towards the nose, because we like to, as surgeons, we sit towards the temple. And so everything we do, we like to go 180 degrees across the eye. And so most of the work we like to do is over in this direction, so towards the nose. But we've gotten good that we can go from the top now to work down. And I actually will sit on the opposite temple and work on the opposite eye. So then we can get into the temporal angle. So we're getting better and better at being able to do different procedures, one in a different area than the other. So if I worked in your nasal angle one day, years from now, I can work in a different section. The only caveat to that is a goniotomy. For a goniotomy, we limit our ability to do additional MIGS. And so what that means is, if you remember, the goniotomy is the one where we strip away the trabecular meshwork. Once that trabecular meshwork is gone, traditional glaucoma surgery and MIGS is gone. And it's just because we don't have any trabecular meshwork to work with anymore. So that's the only caveat, is once that's done, we have to figure something else out.
That makes sense. That makes
Yeah.
sense. That was super helpful. I think you answered my kind of the other questions
Okay.
anyways.
Okay,
Yeah,
good.
yeah, yeah. So you talked about a little bit, what stands out with MIGS and how they differ from traditional glaucoma surgeries. But if you're already on a traditional path of treatment, is it possible to move to the interventional glaucoma or the interventional approach that you were talking about?
Oh, heck yes. That's my favorite to do too. So please don't feel like because you're on medicines, you're stuck there. When we talk about medication in traditional treatment. There's nothing wrong with it, except for the fact it just doesn't work as well as minimally invasives do. And the more data we get around that, the more passionate I become that says, let me be in charge of you. And so I'll have patients that come in 1, 2, 3 medications, and we are able to limit or eliminate those when we're doing these other procedures. So there's never a time where you can't jump off of one train onto the other. So don't feel like you're stuck because you're already in a traditional pathway. I just saw a patient today who is post-tube shunt, which is traditional surgery. And then I did minimally invasives afterwards to get them under better control because they weren't fully controlled. So just because we went one way doesn't mean we can't go back the other. And a lot of times that's part of it, is that it's a lot of mixing all these different mechanisms, feeling comfortable with all these different procedures, and then figuring out what's best for each individual patient to better maximize their quality of life, and then also keeping control of their disease. So yeah, never feel like you're pigeonholed at all.
Amazing. Great advice. Thank you.
Mm-hmm.
Um, so after you apply, for example, maybe laser and drops, but
Mm-hmm.
intraocular pressure persists, do you have any recommendations for next steps? Would you suggest MIGS?
So yeah, I think that's a really good step to suggesting MIGS. It really depends on what we're talking about too, with how effective each one was. SLT, which is my favorite way of doing laser therapy for glaucoma. So just, I know we didn't talk about it, but to back up, SLT or selective laser trabeculoplasty is when I'm putting a very light amount of energy into your drainage structure, into the trabecular meshwork, and irritating it just enough, like a little sunburn, just so that we can have your body heal that drainage structure. For whatever reason, the body sometimes ignores the drain and doesn't want to rejuvenate it. So we're just like pushing it forward. For people who've had SLT, it's also diagnostic for me. So as a surgeon, if I've got good response with an SLT or even decent response with an SLT, that helps me understand that canaloplasty is probably going to work as well. And so that helps me jump to say, okay, we did okay with the SLT, but we probably can do a little bit better if we do the canaloplasty, and maybe we'll stent you while we're there as well. Drug-eluting stents is a really nice mechanism to help with that as well, of getting off the medication that they may be on. So it really depends on how people present to you and how they've been doing with medications, how many medicines they need to get off of, what their eye looks like, how advanced they are. So there's a lot of different data points that we have to put together, but ultimately, yes, that's probably would be the next step for that person, would be thinking about doing a small procedure in the operating room together with minimally invasives.
Great. And we know that dry eye can be one of the most common side effects with glaucoma medications. Is that
Yes.
still the same case with MIGS?
Yeah, so no, so it actually helps.
Okay.
So I live in the desert. Dry eye is abundant, whether we have glaucoma drops or not. And so, I hate making my therapy make my patients' eyes worse. And we see it all the time. So I have people come in and they're pretty miserable with their eye drops for several reasons. Dry eye is definitely one of them. So MIGS actually is going to help with that. So a lot of what we're talking about with surface problems is just the fact you're putting toxic things on top of your eyeball all day. And of course, you need to do it right to keep your pressure down so we don't lose vision. So I am completely understanding of why people continue to do that and be willing to basically make their eye feel worse because they don't want to lose the vision. However, some of us are naughty about not talking about the other options. And the other options are lasers, and then the pharmaceuticals intraocular, meaning in the eye, and MIGS. And if we can use some of those techniques and we can get off of the medication, well, then we're eliminating the toxicity, and thus people's dry eye and surface looks and feels so much better. So we all have plenty of examples that we show in our conferences of pre and post-op patients, and seeing their surface, seeing their eyelids, and looking at the massive difference and improvement that we're giving in people's quality of life and how they're looking and feeling after we do these procedures. So no, this is a totally different thing where the dry eye should improve. The only caveat is surgery does initially kick up a little dry eye. So know that if you had any kind of procedure where we're going inside the eye, even for a couple months, sometimes that dry eye can feel a little bit more prominent, but over time that should really smooth out. And then as the medications are gone, you should be feeling much better.
Great. Super helpful. Thank you.
Mm-hmm.
And you did touch upon cataract surgery, doing it, with MIGS or
Yes.
separately. We do have someone mention here that my glaucoma specialist said that MIGS procedures will accelerate the development of cataracts. Can you please comment?
Sure. So, anytime we go inside the eye, okay, of any kind, you have a retinal detachment, you need retinal surgery, you go into the eye to do, again, MIGS, you're going to be accelerating the development of cataract. Now, it's not like you're going to go from no cataract to this massive cataract in a couple days. No, but maybe say instead of needing cataract surgery in 3 years, you're going to need it in 2 years.
Mm,
But we're controlling your disease. So, just know that if the cataract is there and prominent, I like to take it at the time that I'm already going to do the MIGS. But if there's not much of a cataract there, we leave it alone. But do know that anytime we go in the eye, yeah, there's a potential risk of slight acceleration in the time frame where you need the cataract out. But also know that taking the cataract out is really good for your glaucoma. So it's not usually a negative when I start to talk about cataract surgery. Sometimes I accelerate when I want to do the cataract because I know that that also is going to help with better pressure control. So it's not a bad thing, but yes, yeah, do know that it will make your cataract come out a little potentially sooner.
thank you.
Yep.
Is MIGS available internationally? For example, Canada.
Yes. So they do have different MIGs in different countries. I've gotten to do some talks internationally, and every country has different options available. So in different countries, you just have to talk to your surgeon and see what's available in that place. But they are available in most places. Yeah.
And along those lines, what's the cost effectiveness of MIGS and is it typically covered by insurance?
Yes. So they've done some nice cost analysis compared to drops. And this is in conjunction with also the deliverable pharmaceuticals. And actually, long term finding for patients, a lot of times doing these minimally invasive options are actually less expensive because they are more often than not covered by insurance. There's more juggling with insurance. Let's be honest, insurance hasn't been as friendly as we'd like it to be. But a lot of these procedures are still well covered. And then if you consider that to any copays or deductibles with pharmaceuticals, a lot of times this is actually a more effective approach. I know in the UK they looked at SLT, which is again that laser, and found that it was much more effective than topical medication, and so that's become first line therapy there in the UK. So it's definitely something where, from a patient perspective, this is the very potential to be much more cost effective.
Great. I know this depends probably on each surgeon, but from your point of view, what makes you determine how you choose which device or technique you're going to use for each patient?
Yeah, so I think some of it, you're right, is totally surgeon dependent. When I am teaching other surgeons, I say find the thing that you are comfortable with, that you feel you are the most effective at. For me, because I do so much glaucoma surgery, I get to play with a lot more devices. And it's because I feel comfortable with using all of them. And when I will learn one, and then when I've gotten my hands around that one, I like to use the next thing. And I also like to be able to try out new devices before they become available. So that's how I feel like I'm pretty proficient with all of these things. But when you're talking to somebody, you really want them to do something for you that they think is going to be the most effective for you, but then also that they are good at, right? So some of it is obviously dependent. I have an algorithm that I like to use that I keep in my head at all times of kind of how I'm choosing what I'm choosing. But each surgeon does it a little bit differently. I think the worst mistake in terms of surgeons is not offering these things and not
Mm,
doing these things. I think that's really the bad choice. The good choice is any of them. I mean, cleaning out your drain is great. Stenting your drain will be great. Putting medications inside the eye instead of topically is great. So I don't think there's a bad choice. I think it just comes down to who you're seeing and what they feel is the best choice for you. Again, I think the only bad choice is not discussing these and not offering them.
great advice. Thank you.
Mm-hmm.
And what is the expected decrease in IOP after MIGS? And how long should a patient expect to see results? Sorry, and last bit,
No,
what
that's
is the
fine.
follow-up schedule look like?
Yeah. So traditionally, when we are looking at minimally invasives or actually any surgery when it comes to glaucoma, our goal is a 20% reduction in pressure. Um, I'm going to go on a small, quick tangent about pressure. Pressure is important. We all know pressure is important. It's a very easy measurement for us. But really, the goal is control of your vision and your vision loss. So
Mm.
when I'm looking at true success is keeping the visual field stable. And a lot of our things that we look at in terms of study doesn't look at the field, but some do. Our landmark Horizon trial, which is looking at SLT, looked at stability of field and showed stability of field was greater in those who had laser than those who had topical timolol. And the same was seen in the Horizon trial, which is looking at those who had cataract surgery versus cataract surgery and the hydrus, and finding that also they had a slowing down of progression of visual field by almost double compared to the cataract surgery alone group. So we don't have as much evidence as I'd like to support what we're really trying to do, which is trying to preserve the vision. So from a patient perspective, don't get obsessed with the number, because everyone is different with where their starting point is. So really the goal pressures are different depending on who they are. The big goal is making sure we're not losing vision long term. And so with that, we should get a 20% reduction technically, but if you're already medicated and then you're getting operated on, you may not see a huge swing in pressure. That's okay, because we know we are modifying your disease state. We know we are modifying your drainage structure. We know we are doing a positive thing. So, I always try and warn patients, especially somebody who's, say, a low tension glaucoma patient, you're starting a pressure of 14, but we have advancement. If you come after me and your pressure is still a 14, but I've got stability, I don't really care that you're a 14. So there is that whole component that's hard and also uncomfortable for all of us, right? Of sitting and waiting and making sure we did enough to control the disease. So again, pressure is important, but it's not the only thing. And I think the most important thing is going to be watching your central vision and your visual fields to watch that we're not having progression. Now you're gonna have to give me the rest of that question.
Hold on, now I lost it. I think I said, what's the follow-up schedule going to be like?
Yes. So follow-up schedule. So if you're doing, just because we are talking about laser so much, if you did a laser, I don't see somebody until about 2 months after laser, because that's how long it takes for this to function. MIGS is the same, 2 to 3 months until we get maximum effect. So don't be depressed if you come in for 1 day, 1 week, 1 month post-op and you're not where you want to be. It's not there yet. So give it the time. And it's because we're really asking your body to remodel itself. So we really need the time to let your body do the healing process, because the surgery helps, but it's really your own body's response to the surgery that gets us to the place we want. I like to have my patients follow up after procedure. So anything where we're going inside the eye, 1 day just to check in, just make sure everything's looking good. 1 week, and then 1 month, and then after that 2 to 3 months, depending on, as long as everything's looking normal. So that's a pretty normal schedule for me.
Great.
Mm-hmm.
Patience is a virtue, right?
Yes, I know it's hard. I don't have it. I want it now, like, Amazon Prime ruined us all, but glaucoma doesn't work that way.
You are so right. This is a little bit of a specific question, but
Sure.
definitely it's been asked and it's helpful for our audience. Can MIGS be done with congenital glaucoma with Reiger's anomaly?
That's a hard one. It depends on what the Rigers looks like. So that's one where you will see more scarring. And sometimes you can have a very immature angle. Immature angle, what that means is that you congenitally were born this way and that your drainage structure just didn't develop the way that we would think of a traditional angle to look. So sometimes with Rigers, you have a very non-aggressive Rigers, I guess is the best way to put it, where you have some normal anatomy and you can work on the drain that way. Sometimes I'll have people who their entire anatomy is just so abnormal that we have to bypass the drain. And we'll say, okay, this drain is just not good enough for MIGS, not a problem. Then you have to think about other less invasive options where we're bypassing the drainage structure, which are there. So you still don't need to go to traditional surgery yet. You can still take your time on that. And also the drug-eluting stents are still available for people with Riger. So you don't need a normal anatomy for those at all.
Great.
Mm-hmm.
And what are the best resources for finding a MIGS specialist?
Oh, that's a great question. So through the AGS, which is the American Glaucoma Society, they're going to have anyone who is part of the society in that physician registry. That's a pretty progressive group of glaucoma surgeons. most people who I know through the AGS net are all pretty up on IG. As to how aggressive, we're going to have a wide range. Other things, I actually had a patient find me the other day through these kinds of things. So looking and seeing, we are all posting a lot more online now. There's a lot of virtual talks. And so you can kind of see whose names are out there and who's talking about interventional glaucoma. It's pretty easy just to Google interventional glaucoma surgeons. There's a couple of us that you're going to see quite a lot of. And that's because we're all very passionate and we're the ones who are training everyone else out there in these techniques and kind of being in the forefront. But I would start with, again, the American Glaucoma Society is a really good tool because, again, they have an entire directory of anyone who is part of that society. You have to be glaucoma trained to be on that society list. You have to still be an active member, which is important because that means you're going to the meetings. And really, a majority of the meetings, this is the stuff we're talking about.
Thank you.
Sure.
Um, Also related to kind of like other procedures, can MIGS be performed after or prior to LASIK surgery? Are there any increased risks?
No, so LASIK is kind of independent. That's corneal remodeling and restructuring in order to change your prescription. The only caveat for people who have true glaucoma who are considering LASIK, it's not off the table. You still can do all these procedures afterwards. The only issue with LASIK is it makes it harder for us to monitor your pressure afterwards because it's making your cornea thin. So the corneal thickness actually the only thing it really is going to do for us as glaucoma surgeons and also general ophthalmologists and optometrists is it makes it harder for check pressure because the thinner the cornea, the lower the pressure measures. So it's a false low pressure. So it's sometimes, again, it can kind of give you this false sense of security of like, oh, my pressure's 14, I'm good. But if you have a cornea that's extremely thin, actually it might be 25. So it's just a funny thing that it's hard sometimes to watch once there's been that alteration in the cornea. But again, I still won't stop a lot of my patients if they really need or want LASIK on top of their disease. So,
Okay, thank you.
mhm.
This might is not for patients, but what advice do you have for young ophthalmologists beginning to use MIGS?
Oh yeah. So for young ophthalmologists beginning to use MIGS, one, mentorship is like the key. I just finished an awesome program at Moran Eye this weekend with Fundling's group, and we did a master class. It was all MIGS master class. So there were 7 of us mentors, and we had about 70, 80 surgeons, most who were newer in practice, but even some who've been in practice for decades who really wanted to get more MIGS heavy. That's a great thing. There's a lot of those different kinds of programs. Young MD Connect does it through a lot of different societies. They'll do it. Even if you go to like our national meetings, I know I was just asked yesterday to do a wet lab. So there's a lot of involvement that you can get with surgeons who are doing a lot of that, and then glom on to one of them and say, can I text you if I have any problems, or can I call you? And we're all, I mean, people are pretty open to really helping others, especially because we all are very passionate about getting more patients the ability to get these procedures done. And so we thus have to really spread the word and really help people feel comfortable with that. So I think that those are all very helpful. I always like to watch videos online. I think that's helpful as well. And then there's a lovely resource of also working with all of the different companies that create these devices. They have really good ways of getting you to feel comfortable with, they'll bring wet labs to you. They'll be there to support you through first cases. They can get you hooked up with another surgeon who's been doing procedure for a long time. So all good resources to kind of start stepping up your game with IG.
That's great. Thank you so much. Yeah,
Mm-hmm.
because we get people, not only patients, but we get young ophthalmologists joining us too. So
Yeah. Awesome. Good for you
important
out
to ask.
there. Keep going for it. It's so
Yeah.
rewarding. It's so rewarding to be able to do this for people.
Thank you. Thank you so much. We
Mhm.
would truly appreciate it. Probably just a couple questions left, but for MIGS, do you always do one eye first, kind of like in traditional glaucoma surgery, or would you consider doing both eyes at the same time?
So I do one eye at a time. Reason for it is really honestly, traditionally, we just like to operate on one at a time. It gives me the opportunity to understand how well you did for surgery, if we need to modify anything for the fellow eye, and also just gives people the confidence that their other eye is still there and stable so that they can use that while they're recovering from the first. I obviously take care of plenty of monocular patients. So for those of you who have one eye, don't be concerned about that. Most of these procedures are done topically. So meaning you can see right after surgery. So this isn't something where you're massively incapacitated, you have all this downtime, you're patched up. It's none of that. So we do this as a topical option. It's usually about a 3 to 5 minute procedure on average for me. And then afterwards you're walking out of the operating room with just a shield on. We usually try and keep it clear plastic so that you can see out of it.
Fantastic.
Mhm.
Um, like I said, a couple more questions.
Sure.
Could you compare incisional versus non-incisional MIGS procedures?
Mm. So technically, all MIGS procedures are going to be incisional. It's a great question, but we have non-incisional interventional glaucoma options. So you can think about interventional glaucoma as this large umbrella of different procedures, whether it's injections, lasers, incisional surgery. And then we have within that category, we have the MIGS. MIGS, minimally invasive glaucoma surgery, which they are all technically invasive. So all of those procedures that we talked about today are going to be something where we are going to have to physically get inside your eye one way or another, usually with teeny, teeny, tiny micro incision, usually about 2.5 millimeters at most, sometimes up to only like 1.5 millimeters. So they're teeny tiny, but they are incisions. When we're talking about non-invasive options, that's more laser. So right now, the best laser that we have available is like we've been talking about SLT, but there are lasers that are coming where they're going to make microgoniotomies potentially without incision. So that's on the horizon, starting to get put into trial, but not available yet.
You led me right to my next question, which was, are there new MIGS options or innovations that are going to
Oh,
be
yeah,
coming
there are.
available?
Yes. So there's more stuff coming out all the time. And there's some exciting things. The newest one that should be coming out that I've heard of that should be getting closer and closer to FDA approval is the Elios system that's owned by Bausch and Lomb. That is going to be microchannels that are being created with laser intraoperatively. So we have a laser and we can create 10 small mini microchannels that are done with a laser that's non-thermal, meaning non-burning. So it's a cold laser. It's an excimer laser, and that is going to be almost like making mini stents without stents is the best way of putting it. I was able to trial that when I was down in Panama, and patients were super comfortable. Everybody was done topically. Post-operatively, they looked really good. It's already in Europe. It's been available for a while, and the studies support that it does a really, really nice job. So that's kind of the newest one on the horizon. But yes, this is something where there's a lot more coming. This space is of a lot of interest to industry, which is great for all of our patients because we're getting a lot more innovation. Great for us who love technology because we get to know that there's more coming down the pipeline, but the pipeline is huge. And glaucoma, we know, is a burgeoning area of interest because there's a lot of patients who need help. And so luckily that also means there's going to be more money funding into it.
Fantastic. Thank you for answering our many, many, many questions.
Of
It was
course.
it was super helpful, and you explained it all very well. So thank you so much.
Thank
And
you.
thank you to all of our attendees and for your interest and your support and all your questions. Thank you once again for being here today and for standing with us in our bold vision of a future free from glaucoma. Because of your unwavering support, the cure is truly in sight. Thank you all and see you next time.